So I might have been a little too ambitious with the second set of questions. I think a few of you struggled a little bit more with this one, but the first one I think most of you got, but I want to go through how to do a proper exam with the pen light. So first thing I want you to do is have them look far away. And this is to make sure that they're looking at distance, okay? If they're looking up near, that's accommodation. Their pupils' eyes can change with accommodation, right? The very first question gets at trauma, iritis. What I'm trying to say is that the patient has some mechanical issue with the pupil, okay? So the pupil right here is scar down. It can be small, it can be big, it can be however it wants. It really is just wherever it decided to scar down. It can be from trauma, it can be from irritation or inflammation, whatever it wants to be. But that is a fixed pupil. It can be small, it can be big, it can be heart-shaped, it can be whatever shaped, okay? So looking far away, a light comes on, and you're looking at this pupil. So you're looking at it and you're committing a number to yourself in millimeters of how big that pupil is when there's no light on it. And then you put a light on it and then you compare, right? In this case, it's not going to change because it's all fixed down, right? Or it might be minimal change. So that is a direct response. Then you'll do the same thing on the other eye. And then it'll go back to this eye, light off. But this time you're looking at this pupil, light on. Keep looking at this pupil and watch it constrict. So when you come off, this should dilate. Come on, it should constrict, okay? So that's the first part of assessing, the static pupil that's fixed down. The second part is giving you kind of some information about the optic nerves between them. So, it's hard to gauge how much that optic nerve is firing, but we can use a little trick and compare it relatively how much this optic nerve would fire and how much this one would. So the way we do that is we put the light on the pupil, right, or on this eye, and then we go over this eye, and now all of that stuff that was coming through the optic nerve here, right, is not coming there anymore, and all the signal is coming through here. And so remember, the optic nerve, one way down, but then bilateral signaling back to the brain. So afferent is the optic nerve, efferent are the parasympathetics that run on 3, and then they're going to constrict the pupil when the light's on, okay? So the way we do this is we go from one pupil to the other, switching which optic nerve we're using to constrict our eyes, right? Or to send the signal to constrict. And then we look for any changes in this pupil because we can't use this one. So we go back and forth and we make sure there's no dilation when we go and move over here, right? So if this eye was also damaged, like if you had traumatic optic neuropathy as well, you go over here, it constricts, and you move over here, and it's going to dilate. This doesn't really work if you take a big long break and then move over to the other eye, because then you're essentially just doing, the direct and consensual responses depending on which eye you're looking at. So you need to swing that light from one to the other. And the other thing you need is a more direct light kind of hitting this eye. You really don't want, your cell phone light coming like this and spilling over to both, because that's not really telling you anything, any information. Okay. What I was getting at with the 20/20 there is that this optic nerve would be healthy, this optic nerve should be healthy, and there should be no difference in the response of the pupil. And since we can't use this to tell that, we have to use this eye for the entire exam. The rest of the questions are going to deal with anisocoria, meaning the pupils are going to be different and not from a mechanical issue. So the reason it's important to do this is because when you have an afferent or optic nerve issue, then you have an issue to both pupils, meaning that if the left optic nerve is out, then both right and left pupils are going to be effective. But when we're talking about the ratio of sympathetic and parasympathetic input, right, then we're talking about just the efferent part, and that's what these are going to tease out. And so when you do that swing and flashlight and all those other tests, you're stimulating just one optic nerve individually. Now, if you want to turn down the room lights completely, so it's darker, then you have a set amount of light that's going to both optic nerves, and you're kind of eliminating that portion of the if there's a difference. So for most people, it probably won't make a difference. But if you have someone with, say, asymmetric glaucoma, what you can do is have a really bright room, like turn on all the lights and look at their pupils there, and then dim all the lights, but give it a little bit so you can see the pupil, and then seeing how their pupils are then. That's usually how people assess anisocoria. But again, RAPD is super important because afferent issues present bilaterally. Okay, now we'll go through the questions. Next one is dealing with orbital fractures. This is specifically looking at floor fractures because I think there's some interesting anatomy, and this will help you learn some of those. If you look through here, there's a few different important structures that are coursing along the floor here. So infraorbital nerve, right? And then the inferior portion of cranial nerve 3 are things that I'm really highlighting for this question. And so it's important to remember two things. One, what the actions of each of the muscles are, and then two, what all runs through each of these nerves, okay? So cranial nerve 3 is going to also have our parasympathetics from the Enger-Westphal nucleus, which is really close by to the oculomotor nuclei. And so pupils, right, if the parasympathetics are involved, well, then we're going to have trouble constricting. So you're going to have a dilated pupil. You're also going to have trouble with these muscles right here, medial rectus, inferior oblique. And here's a handy little tool for what each of those do. You know, medial rectus gets smaller medially, so your AD ducting. The horizontals are pretty easy. Inferior, superior, primary is elevation, depression. So in this case, it's inferior, so trouble depressing. So trouble AD ducting, trouble depressing. Inferior oblique, it kind of attaches to more of a oblique angle, although the rectus muscles also attach at slight angle, but that's for a different discussion. But anyway, inferior oblique, you know, the thing to think about is really in certain positions, you're going to have troubles. So at this point, I would just kind of leave it alone until we get to, you know, the specifics of eye movements. But just know movement is going to be abnormal and it's going to be slightly different in different positions. Okay, but we'll get to that in a later question set. So, whoops. The other thing is the infraorbital nerve. That's the sensation loss, and you're looking at kind of the over the zygomatic area for sensation loss. So that's pretty simple in terms of what all I'm asking you for. Pupils dilates because you're cutting out the parasympathetics. Motor, you're cutting out the medial rectus, the inferior rectus, and the inferior oblique. And then sensation, you're getting that infraorbital nerve, so decreased sensation over the cheek. This question gets at asymmetric pupils. It's our first one here. And I'm looking at the sizes. I don't like looking at it like this, so I'll always write it down. You know, 6, 5, this is the right eye. 6 going to 5. 6 is in the dark. 5 is when I put a light on it. Same thing over here on the left, 4 to 2. 4 to 2 is where I think a normal pupil is, usually. For most people, plus or minus 1 on either side of this. Now, are there exceptions? Sure. But most of your pupils, if it's 4 to 2 or somewhere nearby, that's fine. 6, I'm thinking immediately, this is a little bit larger than I would expect. What's going on? Okay. As then if the difference between these is large too, you know, you have a difference of 2 here and a difference of 3 here, I'm getting concerned that this is an abnormally large pupil. So the first thing is identifying which one you think is the bad pupil or the one that's not behaving correctly. So here we have a normal pupil reacting well and one that's slightly bigger than I'd like to think. Then we look through the rest. He's having diplopia and limitations in eye movement. Or what nerve does pupil stuff and movement stuff? Well, it's the inferior third, right? Like the right question right before this. So we're worried about a third nerve, okay? Now, first thing you'll always do is you need to do a slit lamp exam, right? So does this person have iris that's stuck down and it's not moving much because it's just glued down with all those posterior synechia? Well, that may be, but you still need to do the RAPD to make sure that there is no difference in the optic nerve function. Now, if an eye is synec down and it has all of these things, uveitis in the past, trauma, what have you, that's causing all the scarring, well, chances are that the process might have also affected the optic nerve. Okay, so it's not uncommon to also have decreased optic nerve function here, where you're dilating when you move over to this eye. That's fine if it's known and it's not new, right? But just because you're saying it's mechanical doesn't mean you're not saying it's not a new acute issue. Okay, so that's the first differentiator. Is it a new acute issue? If it is, you got to do something about it. Okay. Then the next thing, if you look at that algorithm that's in the book, let me just bring it over here. You know, it tells you to use dilute pilocarpine. I wouldn't think of this as a algorithm per se. I would just use it as an organizational tool. In the ED, if you're spending an hour putting in, diluting pilocarpine and putting it in just to see if someone has an 80s pupil or not, you're kind of missing the point here, right? You're looking at the trees, not the forest, where your patient might have had an aneurysm, and things are going south pretty quickly, or something's going on that you're, not addressing immediately. So you need to prioritize. It's just complicated and you're having difficulty figuring out and you're suspecting 80s people. That's when I would do the dilute pilocarpine. But honestly, I would make sure that we don't have a mechanical pupil, make sure we don't have an RAPD. And then if you want to use pilocarpine, I would dump like 1% pilocarpine on there and see if it constricts. If it's starting to budge a lot, it's a deinnervation thing, and I'm worried about a third nerve, and they're going for imaging immediately. If there's a history, of scopolamine patch or, dilation recently, it's not unheard of that a patient goes to an optometrist or an ophthalmologist, gets dilated, and then they end up in the ED, and the ED is worried about dilated pupil. So, if there's a history and you dump pilocarpine, it doesn't budge, that's pharmacologic to me. If there's any concern for a third nerve at all, even if you're like, I don't think it's a third nerve, but there's still a chance, you need to get imaging. You need to make sure that they're not going to die or get worse. It's a neuro issue. You got to care for the patient. Okay. So that's how I would deal with essentially that right side of that algorithm. This question is getting at Horner's, essentially apical tumor or something, is, do not miss for sure. With Horner's, remember anhidrosis, meiosis, ptosis are the big three that you remembered. Remember that anhidrosis runs on the external carotid and the other two run on the internal carotid. And you don't always have to have all three. And as ophthalmologists, we really pay attention to the ptosis and the meiosis when we're looking at a patient. So this patient, let me go back. This is, you can do a couple things here. One, you're seeing this in bright light and dim light. And that's kind of what the classic description of, better in dark or worse in dark, worse in light things are. Now, what's the difference between this and doing our standard exam, where we're putting the light up and down and doing the direct response and essential response and swinging a flashlight, is there we're picking selectively which optic nerve we're firing at, okay? So most cases, it won't be an issue. Healthy optic nerves, you're switching from one to the other. Now, a case like this, right, when you have the whole light on, remember, you're triggering both optic nerves to fire, okay? So you're kind of getting rid of that APD disparity, if there is one, by doing the entire room lights and comparing the pupil size. So anyway, back to this Horner one. Is there ptosis here? I don't know, maybe a little bit. The MRD isn't super strong. Is there meiosis here? A little bit, right? But not very much. But then we would go to dim light, right? Where sympathetics should turn on and make the pupil a lot bigger. You see this is a large pupil here. And then here, pupil's not so big, right? Ptosis, maybe you might think it's a little more evident here, but remember, this is dilated pupil, so you're kind of comparing apples and oranges, right? The other thing to point out is that ptosis coming from Horner's is going to be a lot less severe, right? And it's going to be harder to notice than ptosis coming from, say, if you completely broke the superior third nerve, causing paralysis of levator. Because remember, levator is the big workhorse, and the Mueller muscle simulated by sympathetics is just doing a little bit, right? So you have a little bit of asymmetry with sympathetic or Horner's, big ptosis that you're looking for. Now, you also have a muscle on the bottom eyelid, so you might have reverse ptosis, meaning that this eyelid is coming up a little bit more, right? Because you have muscles pulling up the eyelid and muscle pulling down the eyelid that are both stimulated by sympathetics. So if this is not being pulled down, it goes up. If this is not being pulled up, it goes down. So essentially, the interpalpebral fissure goes down. But back to Horner's, it's a sympathetic thing, and dark, the pupil isn't getting as big as it should because it's lacking that sympathetic stimulation. Now, apriclonidine, after about a day or two, the receptors here are going to be very hypersensitive, I guess, to the apriclonidine, and then they'll actually do a lot more of the alpha-1 response, causing dilation of the involved pupil. So here I'm giving you a history of a pupil that does not budge at all. The right is 7 to 7. The left is 4 and 2. Remember, 4 and 2 is about normal for most people. 7 and 7, well, that's not moving at all. And this patient, has both eyes dilated. So, let's say this is 7 to 7, 7 to 7, both eyes, and they have this history of motion sickness, right? You're thinking some kind of pharmacological agent that can cause dilation. Okay. Now, you can also get them to look near, because remember, that should cause a little bit of constriction. That's an additional test you can do. But if you dump a bunch of pilocarpine on these, they don't budge, you have a good story, maybe you don't have to do imaging and you save them, in the hospital some money and time and some radiation. Okay. But if there's a good story, you have large fixed pupils, you can check near as well, and you can dump a bunch of pilocarpine. I would not try to tease out 80s pupil in this one. But again, any concern at all, you're going to grab imaging if you're concerned about a third nerve. All right, last one here. This one I was getting at a 80s tonic pupil. I didn't give you enough in the question, so I think that's fair. But essentially, what I want you to think of when you think of 80s is that you're doing a slit lamp exam because that you have kind of odd sized pupils and you want to figure out what's going on. Now you look in and pay attention to how it's constricting and dilating, and it's going to have weird, odd movements. Okay. The reason for it is you have parasympathetic denervation. Remember, parasympathetics make it smaller. That's why we see a slightly larger pupil. And it's denervation of the pupillary sphincter, resulting in this kind of fixed, sectorially fixed iris that still constricts, but not to the same degree as the normal contralateral. This is usually unilateral about 80% of the time, and for some reason more common in females. But again, just like you had in Horner's, the denervation can cause hypersensitivity. So same thing here, except now we're doing parasympathetics. So we're thinking about acetylcholine type stuff, and we're using pilocarpine. So you can dilute it down and you could have a great response to pilocarpine where, you can just follow that chart. So again, being really good at not just light room, dark room conditions, but also being able to do a swinging flashlight test. Because remember, in anisocoria is difference of pupils. So if you have a nerve issue and you have an APD, that's not going to give you anisocoria. That's going to be affecting both of the eyes because it's the signal back, the afferent signal. So you need to do a good pupil exam to make sure that there's no component of RAPD or APD or nerve damage or however you want to say it. And then, you do your workup for anisocoria, have the room lights dark, have the room lights bright. And remember, on all, dark means sympathetics, bright means parasympathetics, because when in the dark, we want to get big, we want to see the bear, so we dilate. And then in the light, we constrict because we don't want to let in all that light, is one way to think of it. The other thing with 80s and all of these pupil things is you can look at accommodation and near and see if the pupils work any differently far away and near. So for 80s, right, they're going to constrict a little bit better with a near stimulus. So that's for cases, or case 2, question 2. All right. Thanks, guys.